In the previous video, we had discussed malignant eyelid tumors. In this video, we will discuss in detail the treatment of malignant eyelid tumors. The primary goals in the treatment of malignant eyelid tumors are complete tumor eradication, confirmation of tumor-free margin, preservation of eyelid function, and acceptable cosmetic outcome. Treatment planning depends on tumor type, size, location, and extent of spread. Biopsy is mandatory for definitive diagnosis of all suspected malignant eyelid tumors. Incisional biopsy is preferred for large or infiltrative lesions, while excisional biopsy may be performed for small lesions. In sebaceous gland carcinoma, MAP biopsies are essential to detect vegetoid spread. Surgical excision remains the mainstay of treatment for malignant eyelid tumors. The tumor is excised with adequate safety margins, and histological confirmation of complete clearance is essential before reconstruction. Margin control can be achieved using frozen section examination, Mohs micrographic surgery, or paraffin-embedded section analysis. Mohs surgery offers the highest cure rates with maximal tissue conservation and is particularly useful for recurrent, infiltrative, or medial canthal tumors. Mohs micrographic surgery involves serial excision of thin tissue layers with immediate microscopic examination. This technique maximizes tissue preservation while ensuring complete tumor clearance and has the lowest recurrence rates among surgical options. Eyelid reconstruction is undertaken only after complete tumor clearance. The method of reconstruction depends on the size and location of the defect and may be performed in single or multiple stages. Small defects involving less than 1/3 of the eyelid can usually be closed directly without significant functional or cosmetic compromise. Moderate-sized defects involving up to half of the eyelid often require local flaps. The tensile semicircular flap is commonly used for lateral eyelid defects to achieve good functional and cosmetic results. Large eyelid defects require reconstruction of both posterior and anterior lamellae. This often involves multi-stage procedures using flaps and grafts to restore eyelid structure and function. Radiotherapy may be used as an alternative to surgery in patients unfit for surgery or as adjuvant therapy in selected cases. However, recurrence rates are higher compared to surgical excision, and radiotherapy does not allow histological confirmation of tumor clearance. Radiotherapy is indicated in patients who are medically unfit for surgery, refuse surgery, or have residual tumor after excision. Certain tumors, such as Kaposi sarcoma, may respond well to radiotherapy. Cryotherapy may be used for small superficial basal cell carcinomas or as an adjunct to surgery. It is not suitable for deeply invasive or aggressive tumors. Chemotherapy has a limited role in eyelid malignancies. Topical agents may be used in selected superficial tumors, while systemic chemotherapy or immunotherapy is reserved for metastatic disease such as advanced melanoma. Regional lymph node evaluation is essential, particularly in squamous cell carcinoma and sebaceous gland carcinoma. Imaging and lymph node dissection are indicated when nodal involvement is suspected. Let's see some tumor-specific considerations. Basal cell carcinoma rarely metastasizes and is managed primarily by excision. Squamous cell carcinoma requires careful lymph node surveillance. Sebaceous gland carcinoma demands aggressive management with MAP biopsies, while melanoma requires wide excision and systemic evaluation. For examinations, remember that biopsy is mandatory before treatment. Reconstruction should only follow confirmed tumor clearance. Mohs surgery offers the lowest recurrence rates, and recurrent chalazion in elderly patients must always be biopsied.